Welcome to the GI surgery debate. Episode 1 takes on a decision every colorectal surgeon makes a dozen times a month, often on reflex, routine or selective splenic flexure mobilization. Two positions, both defensible. Let's hear them, then weigh the evidence. Why is this a genuine debate? Mobilizing the flexure buys colonic length for a tension free, well perfused anastomosis reaching deep into the pelvis. But that length is not free. It costs operative time and it exposes the spleen, the marginal vessels, and the mesentery to injury. There is no randomized trial to adjudicate, and the observational evidence, as we will see, points in opposite directions depending on the operation. That is equipoise, real, unresolved, and clinically important. One clarification before the arguments. Tonight's motion is about mobilizing the flexure to gain reach. It is not about a tumor sitting at the flexure itself. There, formal mobilization and an extended resection are a settled oncological necessity and no one disputes it. Keep those two questions apart. Start with the anatomy because it frames everything that follows. The splenic flexure is the colon's watershed, the frontier between the superior and inferior mesenteric territories. Here, the marginal artery of Drummond is at its most tenuous. At Griffith's point, it is poorly developed or frankly absent in a small but real minority of patients. The arc of Riolan, when present, is an inconstant lifeline. So, after a high ligation, the neorectum you bring into the pelvis depends on this precise vulnerable junction. Which is why length and blood supply are not two arguments, they are one. The case for routine, 6 arguments. First, reach when it matters most. Full mobilization delivers the length for a low pelvic or coloanal anastomosis, where a centimeter is the difference between a safe anastomosis and a tethered one. Second, well perfused bowel to the anastomosis rather than colon stretched to its vascular limit. Third, it permits a high tie for margin and nodal yield without paying for it in reach. Fourth, and this is evidence, not assertion, in diverticular sigmoid disease, mobilization has been associated with a lower leak rate. Fifth, an elective unhurried takedown beats a rescue mobilization improvised late in a hostile pelvis with the specimen half divided. And sixth, in the minimally invasive era, the medial approach makes it a quick, reproducible, teachable step. Now, the case for selective, and here the numbers sharpen. First, no leak benefit where the question is best studied. In 1109 anterior resections for rectal cancer, leak was 21.8% with mobilization and 20.3% without, an adjusted hazard ratio of 0.82. No difference. Second, a consistent cost. Across roughly 13,000 patients, mobilization added about 32 minutes. Third, a real iatrogenic risk, splenic injury in around 1%, and 1 in 5 of those spleens is lost to splenectomy. Fourth, omission when reach is already adequate is non-inferior. Fifth, in that same large cohort, only a third of patients were mobilized, surgeons already select and safely. And sixth, leak is multifactorial. Taking down the flexure treats a variable that isn't driving the outcome. Put the numbers together, 21.8 against 20.3, a hazard ratio of 0.82, 32 minutes added, a 1% splenic injury risk, and the number that frames all the others, 0 randomized trials. This is the evidence base from which we must reason. So grade it honestly. Level 1, randomized evidence. None, the central gap. Level 2, meta-analyses of cohorts establish the time cost, the safety of omission, and the multifactorial nature of leak. And the best single cohort in rectal cancer shows no leak effect. Then the signal reverses. In diverticular disease, mobilization appears to protect the anastomosis. The harms sit at level 3. and everything below that is expert judgment. Notice, no tier contains a trial. If you do mobilize, how? There are three windows onto the same flexure. Lateral to medial, the traditional route along the white line of Tolt. Medial to lateral, following the inferior mesenteric vein up to the pancreas. Efficient in laparoscopic and robotic surgery. And the inferior transmesocolic route, entering the lesser sac from below. And crucially, minimally invasive access roughly halves the risk of splenic injury, a quarter of a percent against 1.5% for open. The modern takedown is quicker and safer than the debate often assumes. And there are places where the debate is already over. Mobilise routinely when the anatomy demands it. An ultra low coloanal or intersphincteric anastomosis, a bulky or foreshortened mesentery, a high tie under tension, or a tumor of the flexure or distal transverse colon. And select, safely omit when reach is plainly adequate. A high anterior resection with a redundant sigmoid that reaches the pelvis without tension. The argument lives in the middle ground between these two. Which brings us to the verdict. Mobilize for the anastomosis, not for the textbook. There is no level 1 evidence that routine mobilization lowers leak, and in rectal cancer, the best data show no benefit. In diverticular disease, context earns it a place. It costs about half an hour and a 1 in 100 risk to the spleen. So mobilize routinely when the odds favor it. A low or coloanal anastomosis, obesity, a short mesentery, a planned high tie, or any doubt at all about reach. Otherwise, select. And whatever you decide, keep the flexure one step away.